here. Good evening, and welcome to our GATS in the virtual community. And for those of you who are joining us for the first time, GATS stands for Georgetown Howard University Center for Clinical Translational Science. And so today's topic, we have Dr. Wortmann and several of our guest speakers talking about COVID, and we're going to be discussing prevention and treatment today. So we're going to be discussing what we have learned so far about COVID-19. We're going to be talking about many available treatments, best practices for prevention, and ongoing clinical trials. So just a couple of housekeeping items. Please don't forget to keep yourself muted during the presentation. And if you're interested in learning more about everything we're going to be discussing today, we are going to be sharing several links that you can follow through our on the chat bots. And of course, we're going to be giving you plenty of time at the end to ask all of your questions. So feel free to type those into the chat bots. And as usual, we welcome all of your feedback. So we want to hear from you. And there will be a survey that's going to be sent to you. So we appreciate you participating in that survey. And before we move on, however, I also want to remind all of our guest speakers as well as our participants, our meeting is recorded. So we ask for everybody to please don't share any personal information when you ask your questions. And our meeting also gets shared on some of our social media platforms. And so GATS in the Virtual Community is a quarterly webinar that we do on Tuesday evenings. And if you're interested in joining us for our next talks, we invite you to visit our website. You can follow that QR code as well to visit us on our Facebook page. And so what we do, we invite researchers to speak about their clinical research, their clinical trials, and various health topics of interest to our community. And so for today's topics, Dr. Glenn Wortmann, Dr. Ken, Dr. Williams, and our presenter, Jejide, do not have any disclosures. So speaking of our moderator today is Jejide Obisishan, and she is the Georgetown Howard University Center for Clinical and Translational Science. She joined in 2014 to serve as a program coordinator for the pilot program and administrative coordinator for GATS at Howard University. She now serves as an administrative director of GATS at Howard, where she manages the fiscal and administrative aspects of the center, provides research startup guidance to new investigators, and administrative oversight of the Howard University Clinical Research Unit. So Jejide, you can take it from here.
Just want to double check my audio is working before I get started.
Yes, we hear you, Jejide.
Awesome, thank you. So as Wendy said, we are with the Georgetown Howard University Center for Clinical and Translational Science, or GUTS for short. And GUTS is a multi-institutional consortium of 62 medical research institutions across the nation. We focus on fostering a strong multidisciplinary collaboration in our research endeavors and aim to spread clinical research awareness throughout our community. The National Center for Advancing Translational Science, or NCATS, funded by NIH, is all about getting more treatments to more patients as quickly as possible. At the GUTS, we leverage our location in the DC metropolitan area, our expertise, and the co-leadership of minority serving institutions to design and implement research that will have a high impact on underserved populations. So those include minorities, people with disabilities, and elderly populations. Next slide, please. So what is research? Research is essentially the process of solving problems or finding facts in a systematic, organized, and objective way. It's using what is known and building on it. Health research is the same thing. It focuses on learning more about human health, testing innovative ideas and new treatments with an aim to find better ways to prevent, diagnose, and cure, and treat illness. Research can move through various stages. So from the bench, where we're perhaps asking, can we invent a solution to a health problem, to the bedside and patients? Could this intervention work in people? Does it benefit patients? To clinical practice, Can it be delivered reliably by a medical practitioner? And then to public health, does it actually improve public health? Next slide, please. Research is essential to meeting those aims I just listed and to improving the quality of life for those who deal with various illnesses. It makes for better doctors and a greater benefit and outcome to patients. People see the benefits of research from various angles. Some see a benefit in accessing new treatments for themselves or for loved ones, for example, an investigational cancer treatment. Some in gaining greater knowledge or awareness in general. Some see a benefit in a chance to play a role in improving the health of their family, friends, and/or community. For example, all of the COVID vaccine trials we've watched for the last 2 years, and in contributing in ways to improve health in the future. All research covers that. Next slide, please. Racial and ethnic minorities in the US, however, have historically been underrepresented in research. Current census and FDA figures show that while African Americans make up about 13% of the population, they make up about 5% of clinical trial participants. Hispanics make up about 18.5% of the population, but only about 1% of clinical trial participants. Participants in clinical research should reflect the diversity of our population, and the lack of representation misses differences in lived experiences, opportunities, and exposure to environmental stressors and toxins among these various racial groups. This has and can lead to interventions that do not translate well into our real world and are not as effective in our communities. So the only way to change that is if we are front and center in the activities of research. Next slide. So that was a little bit of an introduction into research and the framework within which we operate. I'm going to go ahead and introduce our first guest speaker, Dr. Glenn Wortmann. He is currently the chair of Infectious Diseases at MedStar Washington Hospital Center and medical director of infection prevention at MedStar Health. He completed his undergraduate studies at Princeton University on a 4-year ROTC scholarship and pursued his medical education and internship at Medical College of Virginia in Richmond. He fulfilled his residency along with an ID fellowship at the Walter Reed Army Medical Center. He left the Army in 2012 after a 23-year career with tours in Germany, I apologize, I can't quite pronounce that. Thank you. Walter Reed, Afghanistan, and Iraq. Before I have him move forward, if you do have any questions as we're going along, please make sure to put them into the chat box throughout the presentation. That'll make sure that we can capture them later during our Q&A portion. Okay, Dr. Wortmann, you can take it away.
Great, thank you so much for having me tonight and calling in this evening. So I'm going to go over some treatment and prevention issues with COVID. Next slide. So a little bit about our current state. Where are we right now with COVID? It goes up and down. So these are the national numbers, and we're in a good place right now. With the Omicron surge, you can see that great big red line there. We've come down, but it has not gone to zero. So we are still seeing a low level number of cases. Next slide. This is DC specific data, and it mirrors what we see nationally. There was that big surge of Omicron and now low level. But you'll notice this is from April 15th. We're starting to see a little bit of an uptick, and that's what we're seeing at our hospital and around the clinics. We're starting to see a little bit of an uptick with COVID recently. Next slide. Now, some good news. These are deaths. So this is deaths from COVID in the United States. And again, with that Omicron surge, there was a big increase in deaths, but that line continues to go down. So what we're hoping to see is through vaccinations and better treatments, although people may get COVID, people dying from COVID should really drop to low, low levels. Next slide. So as far as the strains that we're seeing, this graph shows you what's been going on since January 8th, and then moving to the right. It's all been Omicron, and a specific variant Omicron called BA2 is now the most prevalent strain. So as of April 9th, the 22nd, the pink bar to the far right, it's pretty much all BA2 variants in our area at this time. Next slide. So a little bit about COVID in general, and it's a very interesting virus because many people are completely asymptomatic. So they'll just test positive, but have absolutely no symptoms. Then if you move to the right, we have people that develop a mild illness. They'll have a typical cold, sore throat, runny nose, a little bit of a cough. But then we get into the moderate illness, and these are the patients that we see here in the hospital. They'll have more severe disease. They'll have x-rays showing evidence of pneumonia. And then with severe illness, they'll need extra oxygen to help them breathe. And then with critical illness, we see people die of COVID. Why is it that some people have no symptoms and some people die? We still don't completely understand it, but it has a lot to do with you as the patient. If you're 22 years old and otherwise healthy, you're going to do fine with this infection. But if you're 70 years old, you've not been vaccinated, and you've had a kidney transplant, your risk of having a critical illness is much greater. So there are some variables you can control, such as vaccinating and getting early treatment, but you yourself as a patient really control where you're going to fall on this spectrum of illness. Next slide. So we'll go over treatment. And first, I'm going to talk about treatment in the outpatient setting. And this is a slide I stole from Dr. Werble, who presented it at a national meeting. And I like the slide so much, I just copied it and I'm using it. But it goes over when we decide to treat people. So if you're in the green zone, so you're under 30, you have no medical illnesses, you're fully vaccinated, and you're not in any medicines that impair your immune system, you really don't need any treatment. You're going to do fine. The risk of you having a bad effect from COVID-19 is so small, you really don't need any treatment. But as we move to the right, as you get older, you start getting into that red zone. If you have some comorbidities, so you have diabetes, for example, you're pregnant, you have COPD or asthma, that's going to push you to the right. If you've not been fully vaccinated, you haven't had your booster, or you're not vaccinated, that's going to push you to the right. Or if you're on medications that suppress your immune system, such as you have a cancer and you're on chemotherapy, or if you've received a renal transplant, all those things are going to push you to the right. So when you test positive, this is a discussion you need to make with your doctor to say, do I need treatment? And if you fall towards the red side, you're going to need treatment. If you're on the green side, maybe not, but on the red side, you definitely need treatment. So when you go and get tested, you kind of think about where you think you fall on this and then discuss it with your doctor. Next slide. So right now, we're very fortunate. There are 2 pills which are available. They're useful if you have symptoms for less than 5 days. So if you have symptoms of COVID, you need to get tested as soon as possible because the clock starts ticking. You only have 5 days to get that treatment in. The number 1 treatment is something called Paxlovid. I'm going to use the trade name because the generic name is too hard to pronounce, the nirmatrelvir ritonavir. It's 3 pills twice a day for 5 days. It's not for everybody. It interacts with a lot of other medicines, and your provider will actually look to see if this drug is safe for you to take. They may tell you, stop taking your statin for a few days while you're on this medicine, but there's some drugs you can't stop. And so this drug may not be for everybody. But if you can take it, this is the number 1 drug, helps prevent you dying and being hospitalized with COVID. The other option is something called molnupiravir. Also needs to be started within 5 days. In the studies, it doesn't work as well as Paxlovid, but it's better than nothing. So if you can't take Paxlovid because of some drug interactions, molnupiravir would be another option for you as far as oral therapies. So again, if you're falling in that red zone, 2 options for you for treatment. Next slide. This is a side-by-side comparison looking at molnupiravir versus Paxlovid. And you can see why I prefer Paxlovid. It had an 89% efficacy versus molnupiravir was 30%. So just not as good. But if you get down to the drug interactions row, that's where Paxlovid has problems. Next slide. There are some intravenous therapies, some IV therapies that we offer to people. So let's say you cannot take Paxlovid and you're a very high risk patient, like a renal transplant patient. Molnupiravir, the other option, probably isn't your best option because it doesn't work that well. Here you want to find a doctor that can get you to something called bebtelovimab, which is an intravenous monoclonal antibody and works very well. We offer it here within the MedStar system, and we can route patients. We've treated thousands of patients with these monoclonal antibodies. It has to be given within 7 days of therapy. There is another option on the textbook called remdesivir, but it requires 3 days of IV infusion. So you have to get a treatment every day for 3 days. We are not offering this within the MedStar system because we just don't have the capability to give an intravenous infusion every day for 3 days. So if you're getting treated within MedStar, we offer the 2 pills, or we can give the monoclonal antibody, the bebtelovimab. Next slide. For inpatient therapies, I'm not going to spend a lot of time on this slide because it's fairly complicated and it's in the inpatient setting. So really your doctors in the hospital are going to make the call about what to do. But basically, if you're in the hospital and you need oxygen, we're going to give you the remdesivir. We're going to give you steroids. If you get worse, there are some other drugs we can use, such as something called tocilizumab, that helps tamp down your immune system. Because if you're getting very sick, it's because your immune system is overreacting to the virus. So it gets very complicated, but this is what I get paid to do. This is what the ICU docs get paid to do. And so we pull out this chart and we look at you and figure out what's the best medicine for you. Next slide. So the best thing to do is prevent it. So for prevention, there are vaccines available. Again, it's become kind of complicated, but your doctor, there are apps on the phone to help figure out what's the best vaccine schedule for you. But in general, it's for pediatrics, age 5 to 11, it's 2 doses. I deal with adults, so it's 2 doses. That's the primary series. Then there's a booster dose, and really everybody should be getting at least the 1 booster. And then there's a second booster after that. If you're over the age of 50, or if you have certain immune compromising conditions, you should consider getting that second booster. But this, again, you should be discussing this with your doctor. They'll say, you know, they really should be telling everybody to get the 2 doses plus 1 booster. And then the second booster is a case-by-case situation. Next slide. If you're one of these highly immunocompromised patients, this schedule is collapsed down. We get you the 3rd dose sooner because we try and get you the peak vaccination as quickly as possible. I'm not going to go through this in detail. I just put it out here because if you're falling into that renal transplant chemotherapy patient, your doctor should be aware of this and get you this accelerated vaccine series. Next slide. And, you know, do vaccines work? You know, the data is out there. We see this every day in the hospital. We don't admit patients who are vaccinated. You know, it just doesn't happen. The only patients we're admitting who are vaccinated are highly immunocompromised patients that don't respond to the vaccine. And this slide shows the difference between the unvaccinated and the vaccinated, and it's a pretty stark difference. Next slide. And then my last slide is something called Evusheld, which many people don't know about. So Evusheld is a long-lasting monoclonal antibody to prevent people from getting COVID. And so it lasts for about 6 months. It's given by an injection. You get it in the buttocks. And it's designed for people that don't respond to the vaccine. So if you're on chemotherapy, if you're on these big guns immune suppressants, I can vaccinate you, but you're not going to respond to the vaccine. And so I will vaccinate you just in case you'll get some response. But then we give you this long-acting antibody, and it lasts for 6 months to help prevent you from getting COVID. So if you fall into one of these patient groups, you need to talk to your doc. We run a clinic here every Friday afternoon. Georgetown runs a clinic, and there's another clinic up at Union Memorial, it's at Franklin Square, up in Baltimore. So within the MedStar system, we offer this to patients. And I think, Dawn, that's my last slide. Great, thank you.
Thank you.
Oops. Did Dr. Khan join?
I don't see him.
Allie or Glenn, I should have discussed this before. Do you want to quickly mention the clinical trial that is going on?
I'm sure we can probably pull up his slides.
Yeah, we have it. We just,
Right.
So with,
yeah, go
do we
ahead.
do this part, Dawn?
Yeah, sure, Ken, great.
Sure. So when they do clinical research, they break it into 3 phases or 4 phases. Sorry, there's a phase 1, 2, 3, and 4. And phase 1 is when you test it in a small number of patients, usually 20 to 100 people, and you make sure it's safe. The most important thing with doing research is to make sure the drug is safe. So they look there and they make sure it's safe. The drug has already been tested in the lab, usually in animals before it gets to humans. But this is the first in human phase. Phase 2 is where they start looking at, is there any efficacy? Does the drug work at all? And they also are looking for evidence of continued safety. And this is a bigger study, usually 100 to 500 people. The phase 3 study is usually where I would get involved. People in hospital tend to get involved. It's a larger study. And you're really looking to see how well does it do compared to what we normally do. Is there a benefit to what's out there already? Is it safer? Is it more effective? So it's usually a placebo-controlled study. And then the phase 4 study is after it's been approved to do surveillance for unusual side effects. Maybe something that happens, 1 in 5,000 people, and it wasn't picked up in the early studies because they were small. So it's an ongoing long-term study to make sure it's safe in the long run. So those are the phases of clinical research. Next slide. So there's a study ongoing through the MedStar network, and it's spearheaded by the transplant physicians over at Georgetown University Hospital, where they have a drug that's been used in the transplant community. And based on some basic science research, these investigators are looking to see whether this drug, belnicacin, works to help prevent the overexuberant response to COVID infection. The participation is voluntary. It's for outpatients who have COVID, and they're given the drug to see if it helps with COVID infection. Next slide. Oh, I guess that was the last slide. So if you have COVID and you're interested in this study, or if you have friends that have COVID, there's the phone number there. There's an email as well. People that participate receive money for your time to offset the time you spend doing the study. And it's a way to contribute to improvements in COVID research.
Great, thank you so much. And thank you for pitching in. We didn't have too many slides on this one. And I believe it's a phase 2. When we look at the diagram, I believe this is a phase 2 study. Is that correct?
Right. It's a small, yes. Yep.
So that's why this is a smaller study. And we'll take questions at the end on anything that Dr. Wortmann spoke about, or even the study. Why don't I, since I'm on now, I could also introduce Dr. Williams. So Dr. Carla Williams is on, and she is a colleague of ours who works closely on the guts, and she is involved in a lot of different research at Howard University, and she's an associate professor of medicine and public health. And she has been the interim director at the Howard University Cancer Center. Her research has been on cancer, but she has also gotten very involved in COVID studies as well. Her work centers a lot on understanding, reducing cancer-related, but other healthcare disparities as well. She works very closely with the community leaders on our guts and promoting it, and also at Howard, and promoting the adoption of healthy lifestyle behaviors and population health, including that in the environment, health policies, and health systems. So I'm going to let Dr. Williams speak a little bit about her research study that's going on as well.
Thank you, Dr. Fishbein. I think my introduction's probably longer than what I have to say, but it's always great to join Guts in the virtual community. And tonight I'm here to talk about a study that I think is very timely now. So as the pandemic has continued, we want to have a better understanding of its impact on people's lives, not just their health, but other ways in which our worlds have been impacted. You know, now we talk a lot about mental health. We've talked about how kids have been impacted in their schooling. And we are doing a study now that's a survey. It is something that you can do from your home. It does require some type of computer device, a tablet or a smartphone. And it's a two-part survey where we ask a lot about you, understanding where you live, how you may have been impacted in your work, how you may have been impacted in your education, health indicators, and the like. And then we ask, several questions about just how your life was before COVID and things that may have changed after. We ask information about if you've been tested, what type of testing you have had access to, what type of testing you are interested in being able to access. And of course, we ask about vaccinations. And so thank you for putting that in the chat. You can learn more through our website, which is part of the Howard University Research Centers in Minority Institutions program. And after this event, we can also provide additional information via email for anyone who does want to sign up. The study takes about, I would say, 40 minutes, depending on how quickly you move through it, 40 minutes, but typically no more than 1 hour. And we do provide a basic incentive for people's time. Is actually $100 for completing both parts of the study. So my phone number is there as well, 202-806-2878. It's difficult to read, but you can click the link and we will provide information after for anyone who's interested in receiving more information by email. And thanks for the opportunity to share this study. And I believe that Yejide Obisishan is coming back to talk about another similar study about life beyond COVID as well.
Thank you, Dr. Williams. And yes, we have another study that is focusing on, again, life after COVID. This study is part of a research project funded by NIH called the RECOVER study, which stands for Researching COVID to Enhance Recovery. The study team is doing this study to understand how COVID affects the body and why some people who did get COVID are still sick many months after being infected with a condition called long COVID, or PASC, which stands for post-acute sequelae of SARS-CoV-2. Next slide, please. So the inclusion criteria for this study, those who are considered eligible, they must be at least 18 years of age. There's no upper age limit. Infected individuals who have suspected, probable, or confirmed cases of COVID infection as defined by WHO criteria within 24 months of participation in the study. And then exclusion criteria are those who have not yet reached the age of 18 and therefore unable to provide consent, individuals in hospice care, and anyone with a serious medical condition that will prevent long-term participation. So individuals with and without SARS-CoV-2 infection are going to be followed throughout the study to identify risk factors and occurrence of PASC. This study will be conducted in the US and subjects will be recruited through inpatient and outpatient and community-based settings. The Howard University side is looking to recruit a large number of participants. If you are interested, we do have the study contact information at the bottom. Study data collected will include age, demographics, social determinants of health, medical history, vaccine history, and details of COVID infection, overall health and physical function, and PASC symptoms. Biological specimens will also be collected at specified intervals and during visits, and some tests will be performed in local laboratories, and others will be performed by centralized research centers or banked in a biospecimen repository. Again, for those who may be interested, for those who did have COVID and have experienced symptoms, or for those who have individuals in their life who may fall within these categories I had outlined, please make sure you take down the contact information there at the bottom and reach out to the study coordinator. And if you have any issues getting in contact, please feel free to reach out to us and we'll see what we can do to get you connected.
Wonderful. Thank you so much, everyone. Thank you, Jejide. And this is the opportunity where we want to let the audience jump in and ask any questions. Feel free to type your questions in the chat box.
And this is set up as a Zoom meeting, so you can also ask your question as well.
I have a question. As a younger individual who is generally healthy, but has parents and grandparents, what should I be concerned with? As people begin to return to normal, and masks aren't as required in different areas. I know Uber's just took it down, but I want to keep my loved ones safe. What should I be concerned with? To achieve that goal of keeping my loved ones safe?
Yeah, that's a fantastic question, and it's something that we're all concerned about. And the problem is you can't control the people around you, and so you're right. Now that masks are down, we're more likely to be exposed to people with COVID. So the first thing is to make sure your parents are vaccinated, and they would probably, based on their age, qualify for the 3 doses plus the 4th booster, the second booster, a total of 4 shots. So make sure they're vaccinated. When you go and visit them, one thing you could consider is getting a home PCR test, those antigen tests, and you could test yourself before you go over and make sure you're negative. It's a 15-minute test, and that would be another level of protection. So if they're vaccinated and then you test yourself before you go over, then you've done about everything you can do.
Okay, thanks. And just one follow-up to that. I don't have the box in front of me, but I when the Postal Service was offering to ship them out, I got those tests. Is that one of the ones you're referring to?
Exactly. Yep. You can use those, and then they also sell them at pharmacies.
Okay, great. Thank you.
And as a pitch, if you live in DC, you could get 2 boxes for testing kits pretty much every single day, along with PCRs that can go into a kiosk. That the turnaround is about 24 hours right now, if you're a DC resident. So please take advantage of what we have.
Sounds good. Thanks for all the information.
Thanks so much for your question. I have a question if no one else is asking anything right now. How effective or how good are the at-home tests in identifying the new variant or the new Omicron subvariant?
They're as good as detecting the other ones. The at-home tests are something called antigen tests, and they're not as good as the PCR tests that Dr. Fishbein mentioned. The problem with the PCR test is there's a longer turnaround time. It takes about 24 hours. So it's not as convenient. But the antigen test, it's quicker, it's at home, it's not quite as good, but it's pretty good.
Thank you so much.
There's a question in the chat. Yes, you.
Sorry, I think my audio cut out for
Yeah.
a moment.
Yeah,
I have a
okay.
question here that says, I've been wearing my N95 at work, even though most are not. My point of view is to be more protected rather than taking a chance, since in Virginia, numbers are rising. Do you think my logic is correct? And that is from Amy Altman.
Yes, I mean, I wear a mask all day at work every day. And that's something you can do. It's like wearing a seatbelt. You wear your seatbelt to protect yourself. So wearing a mask to protect yourself makes perfect sense. And, a lot of this is individual level of risk. But the only way you can really protect yourself is getting vaccinated and then wearing a mask.
Thank you, Amy.
I have a question, Dr. Wortmann, not to put you on the spot, but I get this a lot from people about, children under 5. So, and the data keeps changing, and, and some data now came out and some didn't come out. So people are saying, when can they expect to see some vaccines available for children under the age of 5? Do you have any information on that?
No, I don't have any special
Yeah.
insight into what's going to happen. I think it'll come. Eventually they'll vaccinate children just like they do for flu.
Yeah.
But not there yet.
Yeah, I didn't want to put you on the spot because I know you're presenting what's approved. It's I just get the question all the time.
Yep.
I had a quick question as well, Dr. Wortmann. So the Omicron variant now, that's considered the BA, are they calling it BA1?
We're still in BA2, although that's the primary. Every day there's like little variants that are coming up.
Right. So I've seen some things about that, and I'm wondering if it's different enough to be any more contagious or infectious.
Yeah, there are. I saw those reports about the next subvariant that's coming out, and we don't know it. And even within countries, there's sometimes this variant takes off in England, but then it won't take off in Germany, and then in India one will take off, and then not somewhere else. So it's not uniform. We really don't have a great understanding of why some countries have some variants and others don't. A lot to be learned still.
Right. Thank you.
I see that Dr. Khan also answered. So I do encourage, if anyone has questions on any of the studies that were presented, Dr. Khan, we briefly presented on your study. Is there anything else that you wanted to add? I don't think you had heard.
No, that's fine. Sorry about that. I was late. But yes, no, I think, the encouraging thing about the whole thing is that, and I'm sure Dr. Wortmann's slides tell you that very clearly, is that people who really get sick, that's where we've got a good handle on things. And that's the most important part, people dying. getting mild illnesses, when, we do that all the time anyway, of course. So, and our study is part of that. It's part of the future where we're going to be focusing on inflammation, which is what really makes people sick, rather than, let's say, coronavirus, which we've kind of known for a long time. So, that's really what I wanted to sort of say from my study standpoint. Hopefully, we're going to get some results in the next couple of 3 months. So we're very excited about that.
Great, thank you so much.
We still have quite a few minutes left, but for the sake of moving on, I'm going to go ahead and present on these following slides. But if anyone has a question, we still have a few minutes at the end. This is just talking about our different resources, and we do have a website, our GOTS website, where we have posted several research topics, and we called it Let's Talk About Clinical Research. This is a great opportunity if you're interested in research and learning more about the things that you hear on the news, for you to join, for you to visit this website. You can follow the QR code or follow the link that is being shared. We're also sharing this with you. And we try to put relevant information here for you. Next slide, please. And speaking of resources, a lot of you may be familiar with Research Match, but if you're not, if you follow this QR code, we have a link to Research Match here as well, where you can find if there are any clinical research trials that you may be eligible for, or maybe a loved one might be interested in participating. So this is just all resources for our community. And so as part of our team and our larger team, we support a lot of different investigators with their studies, as you are already witnessing here. And that's why we host this event. But another thing that we do is that we have a participant advisory board. And these are members of our community, just like yourself, who are joining us today, who are interested in research and want to share their opinions. And our researchers are interested in hearing and seeing things through the lens of our communities and potential patients. So we are recruiting for new participants, and this is a link where you can submit your information, your name, your contact information, and we will reach out to you to see if you are a potential member. So feel free to scan the QR code as well and reach out to us. And as per usual, if you have any general questions, we're going to be sharing this link with you, so you can submit your questions, whether it's for our researchers, for ourselves here at GATS. And so we're constantly taking your feedback. And on that topic, we also send out a survey. So we would appreciate if you take a minute to complete that survey, as we take it very serious, and we really look forward to hearing your opinions. And like I said, we have our webinar right now quarterly, and we are looking forward to our upcoming topic, which is on mental health. So put it on your calendars. If you register here, we will send you reminders as well. So right now, our tentative date is June the 28th. And we will for sure let everybody know if that changes, but we're really excited to present and speak to our community about mental health, which is a very timely topic as well. With everything that we have going on, I think that's something that we all need to really be on the lookout for. And it looks like we do have another question that popped up, so we can maybe allow Judith to read that question for our doctors.
Sure.
And our researchers.
So the question is from Dr. Carla Williams. For those who have well-functioning immune systems, do we think vaccines will be more like seasonal flu, annual, or like shingles, less often?
I think they're going to be more often, unfortunately. We're dealing with a coronavirus. We've had coronaviruses circulating for a long time, and we always get colds. Right, every winter, everybody would get a cold again, and because our immune system forgot that the last time we had a cold, and so the immunity after coronaviruses doesn't last very long. So unless there's a major breakthrough in vaccinology, I think we're probably going to need vaccines once a year or so to keep our immune system up.
I think just to chime in on this, I think what we're all looking for is some new normal. And I think that it's going to take a combination of everything that was discussed on here: vaccinations, masks, treatment, and then obviously just asking a lot of questions and participating in research as it comes up, because we're still going to be dealing with this virus for a long time, or some other pandemic virus, not to be, a downer about it, but there probably will be another one. And, and I think it's really trying to find a new normal and what we're all comfortable with. And we're all going to have to find our own comfort level. And I hope that some, at least knowledge, can bring that comfort level to people.
Great.
Any other questions?
No other questions on the chat.
Well, if there aren't any other questions at the moment, I just want to take a minute to thank all of our participants, Dr. Wortmann, Dr. Williams, Dr. Khan, and Judith. Thank you so much for joining our webinar today, and all of our audience for being interactive. And I hope to see you all next time.
Thank you so much, everyone.
Thank you.
you.
Take care.
Have a good night.
Thanks again.